Good evening. Just want to welcome everybody to this evening's monthly provider seminar. We are very lucky to be joined by one of our Motherhood Center clinicians, Dr. Liza Rimsky, who is going to be walking us through dialectical behavior therapy, DBT interventions for the perinatal period. I'm just going to spend a brief moment introducing you to the Motherhood Center. If you're new and you haven't heard of us before, we are a clinical treatment facility that is located in New York City, and we are face-to-face when we're not in a pandemic. But since March of last year, we've been totally virtual. And we offer a number of different treatment arms to women, both pregnant and postpartum, that are experiencing what we call perinatal mood and anxiety disorders. The acronym for that is PMADs. And this includes postpartum depression, anxiety, OCD, PTSD, postpartum psychosis, all of which can happen, as probably all of you know, both during pregnancy and in the postpartum period. We offer support groups to new and expecting moms that are having challenges with the transition to motherhood. We offer outpatient treatment. We have a number of very seasoned perinatal mental health clinicians on staff, as well as reproductive psychiatrists who specialize in medication that's safe and effective to take during pregnancy and the postpartum period. And what we are known for, and our very special level of care that doesn't really exist anywhere else in the tri-state area, is our partial hospitalization program, which we also refer to as the DAY program, which is for, again, new and expecting mothers that are experiencing anywhere from moderate to severe PMADs and require a higher level of care than outpatient treatment. The DAY program meets 5 days a week, anywhere from 3 to 5 hours a day. And it's all virtual, and it's a combination of group therapy, skills, dyadic, individual therapy, medication management, couples therapy, and partners support. So if anybody who's joining us today has a client that you think might benefit from this specialized level of care, please do not hesitate to reach out and let us know. So I see most of our participants have joined. So without further ado, I'm going to go ahead and introduce Dr. Rimsky so that we can go ahead and get started with tonight. Just want to encourage people to, if you have a question, please feel free to post it into the Q&A. We will save about 15 minutes at the end to get to questions. If for some reason we can't get to your question, we will take note and make every effort to get back to you after the fact to answer that question. So without further ado, I'm going to introduce to you Dr. Rimsky, who received her doctorate in clinical psychology from Long Island University in Brooklyn. Throughout her graduate training, Liza's experiences include practicing dialectical behavior therapy in a private practice setting, university counseling, treatment of general responders with ground zero exposure at the World Trade Center's mental health program, and psychotherapy with veterans at the Manhattan Veterans Affairs Medical Center. She completed her pre-doctoral clinical internship at Mount Sinai Beth Israel Medical Center. Dr. Rimsky's treatment approach focuses on using individualized psychodynamic and DBT techniques to care for individuals and groups with histories of trauma and personality disorder traits. Her research examined mindfulness, rejection sensitivity, couples conflict, and relationship satisfaction. Dr. Rimsky is passionate about providing comprehensive mental health services to perinatal and postpartum women, couples, and families. So without further ado, Dr. Rimsky, I'm going to turn this over to you to walk us through the presentation this evening.
Great, thank you. Are you all able to hear me and see me? Do you need to be able to see me? Whatever works.
We can hear you. We cannot see you. We'd love to see you.
Let me see if I can start my video. It is saying you can't start your video because their host has stopped it.
Okay. Well, as you get started, I will figure that out for you.
Great. Thank you. Thank you, Paige. And thank you, Shannon. Thank you for the lovely introduction. I'm very excited to be able to have the chance to speak a little bit about DBT, which is a highly adaptable treatment, and the ways in which we've tried to adapt it here at the Motherhood Center, specifically in our day program. We did a lovely job of introducing the Motherhood Center. So among our objectives, I might sort of cross off number one, because like many DBT therapists, I'm very earnest and tried to fill a lot of information into this presentation, but also want to make sure there is adequate time for questions toward the end. So over the course of this seminar, I will briefly introduce perinatal mood and anxiety disorders, or PMADs, what we treat and what we tend to see in our day program. I'll briefly overview dialectical behavior therapy, DBT, the treatment I'll be speaking about this evening. And throughout the evening, I'll be speaking mostly through the lens of the skills modules, the 4 modules that comprise DBT. And I've actually chosen one skill from each module to sort of highlight and demonstrate how I might talk about it in the program or with a patient, so that we can talk about sort of direct applications of these skills as they may pertain to women in the perinatal period. And so without further ado.
You should be good to go, Liza. I gave you co-hosting.
Oh, awesome.
There
Thanks, Paige. Here I am. Okay. So feel free to ask questions at any point. I know I might save them for the end, but I wanted this to be sort of like a fun and open discussion among colleagues about ways to integrate DBT interventions with the perinatal population. As we like to say in DBT, we like to use the effectiveness skill, what's also known as the do what works skill. So I thought to make this seminar work, it might be fun to just sort of keep it as open as possible, make sure you're getting what it is you wanted from the seminar. And so I've decided what to present just in terms of what I thought might be helpful, but please feel free to chime in at any time with any questions or specific objectives that you'd like to add. So first off, let's see here. Well, Paige introduced us so nicely, but I'll say quickly that I work primarily in our day program. Ours is an independent specialty center that provides mental health care to women in the perinatal period. When we refer to the perinatal period, what we're talking about generally is pregnancy, throughout labor and delivery, and then about a year postpartum. The flagship program at the Motherhood Center is our pastoral hospitalization program for pregnant women and new mothers. And as Paige mentioned, the program provides a combination of therapeutic support, interpersonal process groups, education groups, skills groups, which is what we'll be focusing on today, along with alternative interventions, including restorative movement, art therapy, and others. Patients are followed by individual therapists and meet regularly with a reproductive psychiatrist as well, so highly specialized clinicians. And mother-infant dyadic psychotherapies are made available, as well as nursery care when we are in person, but also in virtual. So what are PMADs? Perinatal mood and anxiety disorders, or PMADs, affect up to 20% of pregnant and postpartum women and can have negative sequelae for maternal child health. PMADs include diagnoses that present during the perinatal period, such as major depressive disorder, dysthymic disorder, anxiety disorders, OCD, trauma-related disorders, and we often see postpartum psychosis as well. These are generally symptoms that coincide with the perinatal period. PMADs are known to be one of the most common obstetric complications with severe impacts on a wide range of maternal infant health outcomes, including increased risk for preterm birth, effects on mother-infant attachment and bonding, earlier cessation of breastfeeding, increased healthcare costs due to untreated mental health conditions, and PMADs are recognized as a leading contributor to maternal morbidity and mortality, with maternal suicide as one of the largest contributors to maternal mortality in developing nations. Suicide is a leading cause of death following birth, with 23% of postnatal deaths 1 year following birth found to be connected to mental health related causes. In addition, the perinatal period is full of important life changes and transitions, taking on new roles and responsibilities at the same time as losing some, for example, breaks in career. New relationships are often formed, old relationships can be lost, and it can be a fraught period in which previous losses are revisited and old wounds resurface. Research also confirms that there is an increased risk of relapse of existing mental health problems in the perinatal period. And perinatal women often present with symptoms that cross diagnostic categories. So as I mentioned, we typically see these 5 on screen in our day program, but it's not unusual that we see someone with, for example, a current major depressive episode who also presents with persistent and severe anxiety. And that's not so unusual in the perinatal population, that you might see an emergence of symptoms that sort of cross categories. So much of the work with perinatal women involves thoughtfully integrating aspects of different treatment modalities that can be applied flexibly, which is why this particular presentation is about DBT-informed intervention. So for the purpose of this seminar, we will primarily focus on the use of DBT skills and how to translate these skills to the perinatal population. This is a set of relevant skills that we have found to be very helpful in this setting, and I hope it will be helpful to you all as well. I'll just briefly overview DBT and what it is. DBT stands for Dialectical Behavior Therapy. It is an evidence-based psychotherapy originally designed to treat individuals with suicidality with a combination of change and acceptance-based technologies. An interesting fact about DBT is that it was developed, but to be able to procure funding to research DBT and its efficacy, Marshall Linehan, its creator, had to identify a diagnostic category that it would address. It was meant to address suicidality, but for the purposes of funding, ultimately borderline personality disorder was identified as the population for which DBT would be applied. I'll speak in a bit about the ways in which it's actually very adaptable and transdiagnostic. So it's not only for women or people who have borderline personality disorder, but just sort of an interesting fact about it. And DBT emerged from attempts to apply standard behavioral therapy to the treatment of highly suicidal individuals, as I mentioned. It is a mindfulness-based cognitive behavioral therapy, and skills training has been found to be similarly effective to a whole comprehensive DBT model. So when we talk about traditional sort of DBT adherent models, we're referring not only to group skills training, but also individual therapy, phone coaching for patients between sessions, and also what we call team consultation, which is when DBT clinicians come together to consult with one another. That sort of 4-pronged approach is found to be just as effective as just skills training. So skills training can be very adaptable, as I mentioned, and highly applicable and very, very effective. Just some core concepts from DBT that I think can be relevant when we are talking about women in the perinatal period. First off, emotion dysregulation is generally what's being captured with DBT treatment. Interestingly, DBT was originally meant to address people whose emotions are classified as sort of out of control or very difficult to regulate. More recently, there have been sort of adaptations of DBT that also are meant to address over control of emotion and help people with, for example, OCPD, paranoid personality disorder, avoidant personality disorder. So really anywhere on the spectrum that one falls with regard to over control or lack of control of emotions is what we refer to when we refer to emotion dysregulation. Emotion dysregulation is defined by Marshall Linehan, the creator of DBT, as the inability, despite best efforts, to change or regulate emotional cues, experiences, actions, verbal responses, and or nonverbal expressions under normative conditions. One thing I'll say that I think can really apply in the perinatal period is that even if effective strategies for coping and regulating emotions have been established, for example, before becoming a parent, the set of new challenges faced when parenting an infant mean it can be difficult to know how to apply and generalize skills that have been previously learned for regulating emotions. When we talk about DBT, the way that we understand emotion dysregulation is according to what's called the biosocial theory. The biosocial theory purports essentially that emotional vulnerability or like a biological predisposition to intense emotions transacts or interacts with invalidating environments to produce what is a very difficult time regulating emotions. That's a very fancy way of saying that some people are prone to heightened emotions or more difficulty regulating their emotions. And then because of a lack of fit with the environment, they might even have to heighten their emotions even more to feel heard. One thing that Linehan defines as a particular concern is cultural ideals for women. This was a pretty interesting thought, I think, especially when it comes to motherhood, is sort of like how women tend to be socialized, especially in Western cultures. There's a lot of bias and sexism toward women. Interpersonal independence, for example, in Western culture is considered the sort of ideal of healthy behavior or effective and skillful behavior, whereas social support is actually the most closely associated factor with well-being among women in the United States. So there's sort of like a mismatch there, and therefore can lead to bias and more difficulty feeling effective with skills. And when we talk about DBT, we are generally talking about a deficit model as opposed to a conflict model. So in the psychoanalytic literature, we're generally talking about conflicts and how people sort of interact with their own problems because of difficulty reconciling conflict. Whereas in DBT, we're typically talking about deficit or skills deficit. So essentially that you lack skills or are maladaptive in certain areas of your life simply because you didn't have the opportunity to learn them. Because again, of the environment that you were raised in, or sort of misattunements or missed moments that produce deficits. And actually, interestingly, DBT has more recently been started to be incorporated into schools and treatments with adolescents and younger children to address these deficits. Transdiagnostic. So DBT has been found to be transdiagnostic. As I mentioned, it was originally made for people who are highly suicidal. It then spanned to include borderline personality disorder as its sort of target diagnostic category. But it also has been found to be helpful for depressive and anxious symptoms, substance abuse disorders, eating disorders, other cluster B personality disorders, etc. The transdiagnostic nature of DBT enables us to be able to target mixed clusters of symptoms. As I mentioned, sometimes we see depression and anxiety together, and that can be very easily addressed using DBT because of its transdiagnostic nature. This can be especially helpful in the perinatal context, given the comorbidity of mood and anxiety disorders. And finally, DBT is highly adaptable. So I'll start talking a bit about how DBT can be adapted for our population, perinatal women. While it was initially developed to target dysregulation across areas of very complex problems, it has also been adapted for multiple populations, as I mentioned, and dysregulation for women in the perinatal period can be really profound in that there is a lot of transition happening in things like self and biology and hormones and emotions. And so the perinatal period is rife with tinder for emotion dysregulation, and that's why DBT can be so helpful. These skills can be especially relevant, especially as common emotional vulnerabilities in motherhood can increase, such as physical discomfort and lack of sleep. Interestingly, there is evidence that reduced self-compassion, increased self-criticism, and maladaptive beliefs about motherhood, for example, good mothers never fail, are associated with psychopathology during the perinatal period, and DBT skills can really target these kinds of maladaptive beliefs and lack of assertiveness skills and lack of self-compassion. And so that's one of the reasons why they can be so highly adaptable for the perinatal period. All right, let's shift to talking about skills. In DBT skills training, the primary emphasis is to help clients learn behaviors that can be used in place of maladaptive or ineffective behavior. So again, when DBT was initially brought onto the scene, that was to address things like self-harm or chronic suicidality, parasuicidal behavior, or non-suicidal self-injury. But as it has been shown to be highly adaptable and transdiagnostic, and these things can be helpful for all kinds of disorders and conditions. Skills training tends to be didactically focused. That means there's a heavy emphasis on skills training, including modeling, instructions, stories, examples, behavioral rehearsal, feedback and coaching, and homework assignments. Skills for each module can be transcribed on handouts and worksheets. For the purpose of this presentation, I've shown a couple of the ones that are traditionally taken from the skills training manual, and I've also chosen some that we've adapted at the Motherhood Center and sort of used our own interface to convey some of the things that we want to teach, for example, sleep protection, which I'll get to soon. There are 4 modules of skills, which you see here: core mindfulness skills, distress tolerance skills, emotion regulation, and interpersonal effectiveness skills. They are separated into the acceptance skills. Those are the pink ones, core mindfulness and distress tolerance, and the change skills, emotion regulation and interpersonal effectiveness. This is sort of one of the quintessential things about DBT, is that always in DBT, we're attempting to balance change and acceptance. And this is something that makes DBT truly unique. If you think about most psychotherapies, there's really an emphasis on change, changing your patterns, changing your symptoms, down-regulating negative experiences. In DBT, we also sort of really emphasize the need to accept where it is you are in your life and what it is you're going through and what's gotten you there. And this emphasis on acceptance is actually quite unique to DBT. Even someone like Carl Rogers, who was known to be pretty accepting and sort of client-centered, was ultimately talking about change and how to change how one relates to their own experiences. Whereas DBT is really thought of really embracing acceptance technology sort of uniquely compared to other treatments. So let's get into the modules. I'll start with core mindfulness. So mindfulness is central to DBT. These are labeled as the core skills. The reason being that every skills module, including the other three, has at least one mindfulness skill inside of it. For example, mindfulness of current thoughts exists within the distress tolerance module. Mindfulness of current emotions appears in the emotion regulation module. Mindfulness of others appears in the interpersonal effectiveness module, etc. The mindfulness observe and describe skills, which are sort of the what of mindfulness, observing what's going on inside and outside of you, and describing, like labeling one's experience, appear in nearly every worksheet within the DBT manual. The core mindfulness skills are behavioral translations of common instructions given across Eastern and Western contemplative practices. So this is really where Linehan brings in the acceptance piece of what is DBT skills. It's sort of like how to sort of bring complete awareness of the current moment with non-judgmental effectiveness to the present moment. The goals of mindfulness are to reduce pain, tension, and distress, increase control of one's mind, and experience reality as it is. So as I said, mindfulness can be really defined as just complete and present moment awareness, moment to moment, one thing in each moment, and not something like mindlessness, which might involve multitasking or trying to do 6 things at once. The example I like to use with patients is that, sometimes when you drive your car, for example, you sort of get to where you were going, your destination, and think like, how did I get here? I just sort of zoned out and got to my destination. That would be mindlessness, right? If you were truly mindful, you would be doing one thing in each moment. You would be feeling the steering wheel within your hands. You would be paying attention to that clicking noise of the turn signal, etc. So the mindfulness skill that I picked for today to discuss would be wise mind. This is one that can be a little bit sort of like funky and very much embraces the Zen nature of the mindfulness module. However, I find that patients really take to this one. And I work with several women right now in our day program and even an outpatient who were previously in our day program who are constantly talking about their wise minds and what their wise mind was telling them earlier in the day or what sort of came to them when they asked their wise mind a question. And so I thought I'd highlight it for this presentation. Wise mind is a Zen concept once again, and it's sort of thought of as this like spiral staircase or well within your mind and body that you can sort of access when you're in a very wise state. It's also thought of as the marriage between what's called reason mind and emotion mind. In the skills manual, it's referred to as reasonable mind. Other people refer to it as rational mind. But I think these terms can be kind of favorable. And so I use reason mind because I think it really captures what's actually meant by reason mind, which is a very cool, rational, task-focused, sort of logic-oriented approach to one's problem. I like to think of is it Data from Star Trek? The sort of robotic, I'm going to age myself and make myself seem not that attuned to Star Trek, who interacts with information only and data only and doesn't really have emotions whatsoever, doesn't really have any sort of what we call like a hot mind, emotion mind, mood dependent mind, isn't accessing passion or emotion moment to moment, really just sort of data driven and sort of computerized. When in reason mind, people are ruled by facts, reason, logic, and pragmatics. Values are less important, feelings are less important. And this can be sort of a rough place to be in motherhood because you really want your emotions to help you attune to an infant or attune to your inner experience. And therefore, you want to draw from emotion when you're in reason mind, and actually vice versa. When you're in emotion mind and your emotions are very hot and you're ruled by moods, feelings, and urges and sort of out of control by reason, you want to also draw from reason to be able to bring some logic into your process. So therefore, wise mind is sort of the wisdom within, the merger of the two, seeing the value of both reason and emotion, sort of marrying them to each other, bringing left brain and right brain together, or taking the middle path, sort of finding the balance and wisdom that one needs in pregnancy and in postpartum to become sort of an attuned and reasonable, mother, while also invoking logic from what you read in books about childcare or taking care of yourself in pregnancy or what to expect for labor and delivery, really drawing from both to be able to sort of have everything to your advantage, all of your resources. I would ask at this point if there are questions, but I know we have to wait for the end, right? We will get there soon. But that is mindfulness. I'd like to shift to distress tolerance. This is our other acceptance-based module from DBT. Distress tolerance generally addresses the aim of teaching individuals to accept, find meaning in, and tolerate distressing experiences in their lives. They consist of self-soothing skills, or what I like to call the delay of gratification skills. They're aimed at surviving crises or very challenging moments without making things worse. They also enable you to sort of accept reality as it is and have a radically open and accepting stance towards reality and become free from having to satisfy the intense demands of desires, urges, or intense emotions. I like the distress tolerance skills probably the most because individuals can be encouraged to think about how they can apply the skills and knowledge not only to themselves and self-soothing, but also to the babies. And it can be something that can be sort of shared in together. And let's move on to our example. The skill that I chose for distress tolerance is the stop skill. This not only demonstrates a distress tolerance skill that we like in DBT, but it also demonstrates the tendency of DBT to utilize acronyms quite a bit. The stop skill sort of is what it sounds like. And my colleague, Dr. Vasquez refers to this as like the first distress tolerance skill, the one you do first before you can practice any others, such as pros and cons or tipping the temperature. And it basically suggests that you stop doing whatever you're doing. It literally suggests that you freeze. Often the worksheets indicate that you visualize a stop sign and really stop in your mind. You can take a moment, take a step back, take a breath, go elsewhere. I worked with a family at one point in a family skills group where they would use the T as take and take the dog for a walk. That was a way that they could actually physically remove themselves from their home or situation to sort of like regulate themselves if they needed to take a moment. Observe, this is one of our mindfulness skills, sort of pause, observe what's going on inside of you, internal sensations, what's going on for you in the moment, thoughts, emotions, sensations, feelings, and also what's going on outside of you. So this can be especially helpful in a conflict or in a very sort of hot, quick moment where you might otherwise do something impulsive and you just want to take a sec to observe what's going on in the situation so that you can ultimately proceed mindfully, act with awareness, think about what would be the most effective way to move forward in this case, perhaps give yourself some encouragement if that's what you need to do, which is another distress tolerance skill, and move forward with as much effectiveness as possible. Like I said before, we like to do what works. I think the best way to practice the stop skill with the perinatal population, often how this comes up for me, is when there are women who become so overwhelmed in the postpartum period with their infants and say things like, I didn't know what to do because the infant was like clinging to my body, it was being my Velcro baby, and I couldn't decide what to do next in order to soothe myself or tolerate distress or practice a skill. And I like to say that the stop skill can be practiced simply by putting an infant down or putting an infant into a crib for a couple of moments, whatever you need to do to just sort of literally stop what it is you're doing. So as to address something that you might otherwise do that might be impulsive or make things worse, and just think about what's happening for you in that moment and what's going on outside of you too, and proceed with mindfulness. So that's a way that we talk about practicing the stop skill. And like I said, it's meant to address impulsivity. And it really is like the first skill that one should practice. And the skills are meant to be done sort of boom, boom, boom in tandem. I want to pause because I've now covered the acceptance modules, including mindfulness and distress tolerance, but I covered them quickly. And I wanted to see if we could break to see if there are any questions before I move on to the change skills modules. I see a chat, but I'm not able to click it. Are there any questions yet so far?
Liza, we do have a question that I can post to you.
Great.
This comes from Caitlin Wilbur-Smith. I'd be interested in hearing how you use DBT strategies to support women following perinatal loss. both early loss and late-term loss and pregnancy after loss.
Oh my goodness, I feel like that could be a seminar in and of itself. Loss is so hard and often can be traumatic. Interestingly, DBT does have sort of a frame for addressing traumatic experiences and trauma. It's generally considered like a level 2 thing to address, level 1 being life-threatening or life-interfering experiences, and level 2 being things that impair your ability to feel things fully, such as inhibited grieving, which is a trauma concept, or something like loss, to use your point. I think the skills that come to mind offhand that would be most important with loss, as hard as they would be the acceptance skills, the radical acceptance skills in particular. Actually, those were inspired by Viktor Frankl, who's the author of Man's Search for Meaning, his book is about finding meaning in his experience with a lot of loss. He lost his wife, who I believe was pregnant in the Holocaust. And so he had this way of sort of interacting with reality, as difficult as it was, with sort of like acceptance and grace, and tried to make meaning from his loss, as difficult as I imagine that was, and really accept life as it was and sort of try to understand how to move forward. And I imagine that those would be the skills that would be most relevant. Toward the end of the seminar, if there's more time, I can elaborate on radical acceptance and how they can sort of be practiced and applied. The radical acceptance skills are themselves 6 skills, which are radical acceptance skills, because as you can imagine, radical acceptance is, first of all, extremely challenging, but second, something that has to be practiced over and over again. You can't, for example, overcome something like pregnancy loss and then just have accepted it and be done with that. You have to do what we call turning the mind over and over again. When reality is something that's very, very difficult to accept, you have to sort of accept over and over. And there's some really interesting skills within the radical acceptance category that draw on a lot of empirical research that has been really interesting, that sort of facilitate the process of acceptance, as difficult as it can be. So I hope that answered your question about loss. It's obviously a big topic that would require a lot of care and attention, and I'm happy to cover it again toward the end if there's time. And I hope that answered your question, Caitlin.
Liza, I don't see any other. Oh, here we have another one. We'll take one more.
Thanks, Paige.
Could you give another example of a common example of using the wise mind skill with this population?
Yes, and I'll even go back if I can to the previous slide. So the example that comes to mind with wise mind that I should have shared earlier actually is one that I think can be really helpful for understanding the ways in which wise mind can be helpful, and actually reason mind can interfere. I can't go back, but if you remember, it's a Venn diagram, and reason and emotion sort of meet in the middle to make wise mind. So reason mind, as you can imagine, gets sort of like a sexy reputation because people are like, oh, I want to be reasonable and I want to incorporate reason into my process. And it can be very difficult to generate an example of the ways in which reason mind can actually be inferior to something like wise mind, or why wise mind is actually ideal. But the example that I like is directly related to parenting, so it can be very helpful with this population, which is that if you have, let's say, an older child who comes home from school and says, oh, the teacher was really mean to me, and I really didn't like how they spoke to me, and then they gave me an F on my test, or whatever it is, they didn't like my assignment, etc. Someone in reason mind, a parent in reason mind in particular, might do what? Well, perhaps the audience can't chime in, but I would like to think that a parent, or perhaps my parents back in the day, might have sort of called the school and tried to intervene directly and sort of make a complaint about how the teacher was unhelpful or wasn't particularly supportive or educational toward the student. And that can be a very sort of reason-oriented, logic-oriented, what we call problem-solving approach to something like your child having a difficult day. However, the wise mind approach in that situation might be to do what? Again, you can't participate, so I'll tell you that a wise mind approach might incorporate that sort of like, I can call the school and see if there's anything that I can do, but would first sit the child down and ask them something like, what did it feel like to be talked to like that by your teacher? It sounds like you've had a really hard day. How can I be there for you and validate you? And that's another example of wise mind that I like to use because it really draws from both emotion and logic Parents love to be problem solvers, but often can invalidate in the process. So by incorporating both emotion and logic, you can sort of tap that wisdom and really be there for a child and attune to a child and mentalize their experience, and also draw from logic to solve their problem if you want to also be sort of directly helpful to them. So that would be another example of wise mind that pertains to parenting, although parenting may be a little bit an older child as opposed to an infant, because it could be really hard to validate an infant, although mirroring is generally how we talk about doing that, sort of staying attuned to their moment-to-moment gestures and experiences. So that would be another example of wise mind. And if there's time at the end, again, I'll try to come up with some more to be of help. I will move forward to get to the change modules and spend time doing 2 more skills, and then we'll get to questions. So when it comes to the emotion regulation module, this can be easily confused with distress tolerance. Of course, distress tolerance is sort of momentary acceptance or maybe longer term acceptance of something that's really difficult, sort of the delay gratification skills that I mentioned that help you stop when you're in a very hot or impulsive mind and you really need to sort of delay something so as not to make something worse. Emotion regulation is what I like to call the sort of self-care skills, and they're generally aimed at reducing unwanted emotional responses, increasing desired emotions as well. So this is something that I think is really fun about DBT that I remember one of my professors saying to me in graduate school is that most psychotherapies address how to downregulate negative affect, right? You want to reduce depression, you want to reduce anxiety, you want to have less traumatic re-experiencing and other symptoms of sorts, but very few therapies talk directly about up-regulating positive emotions or pleasant experiences. In DBT, we do suggest doing this. And this is actually one of the DBT skills that I most use with mothers. For the purpose of this presentation, I identified sleep hygiene as the emotion regulation skill that we talk about. But if there's time at the end, again, I can talk a little bit about what's called ABC Please, which is a skill that's meant to help people have more positive experiences or have more pleasant experiences, which can be a really fun skill to talk about, especially with new mothers who have to be really creative about ways to find the time and energy to upregulate a positive emotion, because it's not like they can just sort of like bring their brand new baby to a pottery class or something like that. So for emotional regulation, I wanted to talk about reducing emotional vulnerability, since this can be so paramount in the postpartum period, as well as the perinatal period, as sleep can be very difficult for all women in the perinatal period. We teach that things like not treating physical illness, not eating in a balanced way, or exercising, or getting long spans of sleep can be really damaging to the emotion sort of system. You can all sort of identify, I'm sure, with the term hangry, that one is especially hungry, might have a sort of quicker temper or go from 0 to 60. And that could be really true of sleep protection. We really want to protect sleep and get lots of rest so that you are more able to regulate one's emotions. One thing I like to say about emotion regulation is that it's kind of like a tank that you fill at the beginning of the day. For those of you who have perhaps like dieted or tried to be really sort of good and controlled in a particular way, probably find it easier to do so earlier in the day and earlier in the week, because one's capacity for ego control or emotion regulatory capacity has a tendency to diminish sort of over time as you become more tired and strained of having sort of flexed that emotion regulatory muscle over the course of time. It sort of weans. So the emotion regulation skills focus on how to manage one's physical experiences that might predispose them to emotional vulnerability or sort of impatience, but we also talk about identifying and describing emotions, changing emotional responses, reducing vulnerability to negative emotions, such as protecting sleep, and managing difficult emotions. So one thing we talk about quite a bit at the day program in the Motherhood Center is protecting sleep for women in the perinatal period, but we also have an infant sleep group, and we have an adult sleep group as well. So Dr. Woods, our sleep expert, actually did a provider seminar, I think most recently, and it had a lot of information about sleep and how to protect sleep and how to use CBT for insomnia methods to have the most hygienic possible sleep and the longest duration of sleep. And so I thought for emotion regulation, I would highlight sleep because I think we spend so much time talking about it. And this is a great way to practice something that will enable you to better regulate your emotions so that you can be there for your baby. Okay, and then the interpersonal effectiveness skills. So this is a really interesting module. It only consists of 3 skills, but I think they're very, very full. And ultimately, they sort of derive from a need for people who might be eligible for DBT, such as people who are suicidal or with borderline personality disorder, or in this case, perinatal women, to have more assertiveness skills. As I said before, there are some issues with in the biosocial theory that are identified related to sort of like sexism, or it being sort of seen as a bad thing to need to depend on others. And that can certainly be true in the perinatal period. And it's very important to have skills in place to get your needs met by others, to be able to ask for help, set boundaries, build relationships that feel helpful, end relationships that feel destructive, say no, and then also create and maintain balance in relationships. One thing we talk a lot about at the Motherhood Center, as you can imagine, is the impact of new parenthood on marriages or romantic relationships. And these interpersonal effectiveness skills can become tremendously helpful when it comes to negotiating things within relationships. Because of the sort of assertiveness emphasis that comes with it, or the interpersonal effectiveness module of DBT, I thought I'd identify FAST as the skill that we'd use this evening. This is what we refer to as the self-respect skill. This is the one that can be most helpful when it comes to sort of getting one's own needs met and putting one's relationship with oneself first before other relationships. So when we talk about the FAST skill, we talk about being fair, practicing fairness, being fair to oneself, but also others. We also talk about no apologies. Don't apologize unless it's warranted. Don't apologize for needing what you need or wanting what you want. Stick to your values, stick to what's important to you. Don't make compromises for the sake of a relationship if what you're actually trying to prioritize using your skills is your relationship with yourself or your self-respect, your FAST skills. Stand up for what you think is important. And then be truthful. Avoid dishonesty, including exaggeration, lying, or acting helpless. Be truthful to yourself as well as to others. And it's very hard to have self-respect if you're also prone to lying. So that's why we emphasize being truthful when it comes to the FAST skills. I'll talk about an example of the FAST skill. I actually used it with a patient earlier today and thought, oh, this is great, because later tonight I'll be talking about the FAST skills. And I was working with a woman today, an outpatient, who wants to explain to her mother that she's separating from her husband and will be wanting to live with her mother for more time than they previously thought about, and than they previously had planned for. And the patient was talking today in her session about having told her mother originally that she'd be living with her mother for the course of time that she would be separated from her husband, and that it would be temporary. But that recently became clear to the patient that it wouldn't be a temporary separation, this would ultimately be a divorce, and that she was going to have to ask her mother to live with her for a longer time with her baby. And the patient was talking about just this sort of conflict she was having around knowing this truth, that she'd be asking for more time and that it would be a permanent change as opposed to a temporary separation, and feeling really sort of fraught around having not shared this truth with her mother, even though she sort of realized it with her husband fairly recently. And so I talked to her about the FAST skills and how she doesn't have to apologize for having not realized this truth until fairly recently. And, it is important to share the truth, which is that she's decided that she needs to make a change in her life and live with her mother for some time, and to come up with some ways to maybe make it more fair for her and her mother. So for example, she might come up with a schedule wherein she would rely on her mother, at certain times of day for help with childcare, but also stick to values of sort of like standing up for what she needs and asking for help, because that's something she really prioritizes in her life. She happens to be the mother of a female baby and wants to even sort of honor and demonstrate, asking for what she needs and asking for help and not apologizing. And so we talked about how she might practice the FAST skills in that regard and explain to her mom that she would be sticking around and, sort of do so in ways that would be fair to her and her mom, but without apologizing, because needing to live elsewhere from her husband was actually a very important thing for her at this time in her life. I will just wrap up quickly and talk a little bit about how I hope this seminar was helpful to you all, and then I will make room for questions. So as I mentioned before, there have been many adaptations of DBT programs that have been efficacious. And actually part of the spirit of DBT is coming up with ways to find empirically validated skills to be helpful for a wide range of populations presenting with complex problems, or even less complex problems, but really anyone who can benefit from the interventions. Interestingly, though, there is a dearth of literature about using DBT interventions with perinatal populations. I was actually only able to find 1 or 2 studies that involved very, very small samples of women comparing DBT protocols to basically lack of treatment or a very simplistic CBT protocol. So actually, it would be great if over time there was more of a hardy literature source about using DBT skills with women in the perinatal population so that we are able to address deficits in things like mindfulness skills, distress tolerance, emotional regulation, interpersonal effectiveness, and help women in the perinatal period in a way that sort of is effective and does what works, as I said before. Fortunately, we at the Motherhood Center have been able to utilize these DBT-informed interventions in our PHP and have used these skills in a course of our own sort of modified 4-module scheme that takes about a month. And it has been very helpful, I believe, to women with in the perinatal period, many of whom are in crisis, but some of whom can just use skills for building a life worth living and finding meaning in their lives and in motherhood and in profound transition, as motherhood generally entails. I hope that this seminar has been helpful in enabling you to understand the ways in which you might be able to use DBT interventions to sort of flexibly work with and apply skills with the people that you work with, especially women in the perinatal period, and would welcome any questions at any time. Here are some recommended resources. This is what we call the text, CBT for borderline personality disorder. This is the original book that details DBT and its development and how to use it sort of from a frame perspective. And then the DBT skills training manual on the right is the one that outlines all of the skills and the examples and ways that can be applied and used. These are the references that I relied on for this presentation. And I just wanted to thank you all so much for joining and would welcome any questions. Please feel free to follow up at any time.
Thank you so much, Dr. Rimsky.
Thank you, Paige.
I have a question that I will read to you so you can take a sip of water. And then if time permits, you did drop hint of maybe revisiting radical acceptance, which I think is such an important skill that maybe folks will like to hear about if time permits. But a question from Leah. Thank you, Dr. Rimsky. My question is, do you have any guidance on how to incorporate these DBT modules in individual psychotherapy? Since much of it seems to be about teaching skills, it makes sense to me how that's done in a group setting. I find DBT to be difficult to incorporate into individual sessions at times, as those sessions tend to be centered around the patient and providing therapeutic holding, etc.
Yes. Such a good question, Leah. Thank you. It's so true that when you're in an individual session and not sort of a DBT skills training environment, it can actually feel really sort of hard or difficult or awkward to sort of bring up the skills. Actually, one of the sort of downsides about DBT, I would argue, is sort of that there can be some amount of invalidation and sort of being like, hey, you probably never learned this thing that might be helpful to you regarding sleep protection, and wouldn't you understand that it would make you less vulnerable to intense emotions, etc. But I actually find that, especially with the women that I work with, they are generally so interested in learning something new about, for example, what they might be going through biologically or socially in the perinatal period. And if you say something like, I actually know of a skill that I've found has been really helpful for people in a similar situation to you, or that can be helpful to me sometimes, that can be a great way to sort of have a foray into a skills conversation. DBT is actually very sort of keen on modeling. So you might talk about how this skill has been useful for you in your own life or in your own relationships. And right now we're doing all of our work virtually. So I'll even pull up a handout and walk through the steps and talk a little bit about the Venn diagram, if it's wise mind, or if it's stop, like how you might take a walk or take a moment and freeze and visualize a stop sign in your mind. Sometimes it can be a little clunky to be like, all right, I'm pulling something up now. But it actually can be really helpful, I think. And like I said, especially the women we work with, they're so interested in learning how to be better mothers and sort of better partners and better their lives, that when you say to them, like, actually, I have something that empirically has been found to be useful, it's a skill, and I'm just going to walk you through it as if this is a class, they're highly amenable and actually really open and enjoy sort of brainstorming or engaging around it. Just yesterday, I was doing a one-to-one with one of my day program patients. And I pulled up from the emotion regulation module the pleasant activities list. As I mentioned before, there's one skill that's sort of meant to target upregulating positive experiences and positive emotions. And she and I just went through the list together and we were like, which of these do you think you could practice? Which of these do you think you could bring your baby to do with you? And we had a little bit of a laugh because some of the pleasant experiences that are suggested in this list are like kind of funny, such as collecting stamps or flirting or thinking of how you might plan your wedding or whatever it was. And I would say just that session was kind of a pleasant experience because we were sort of laughing and being playful around ways she might practice the skills. So anyway, all this to say that I think you just say in a session, look, I've got a skill for this. I think you'd enjoy learning about it. Can we talk about it for a few minutes before we come back to, that issue you're dealing with where you needed a lot of support and holding? And generally the patients are really amenable and excited to learn.
Thank you, Liza. We have a couple more questions, but I just also want to piggyback on that last one. One thing that I think translates incredibly well to individuals, since so many clients and patients, regardless of them being perinatal or not, run into conflict and are also looking for effective ways to ask for things that they want and need by using the Dear Man skill that we didn't reference here today, but is another super popular one. I will have everyone know we co-opted it as Dear Woman. As we treat perinatal women at the Motherhood Center, but another really helpful one to pull up if a patient needs that kind of prompting in an individual session. Question from Caitlin, do you use other aspects of DBT with this population, like a diary card, or do you mostly incorporate skills training into individual therapy?
That's a great question. So actually, I would say that I personally incorporate quite a few like individual DBT interventions. I have the good fortune of being part of a day program where the skills are being taught for an hour a day, a different skill each day. So I actually do less skills training and more of those individual interventions that you're speaking to, such as diary cards or behavioral chain analysis or a missing links analysis. These are all things that I can cover quickly to describe what they are if they're new terms. I find diary cards to be tremendously helpful. I consider our treatment to be pretty immersive, but I would also say that sometimes I feel like I would just like to see these patients like every day for an hour. And sometimes a diary card can sort of guide a session because in fact, we generally see them for about 45 minutes twice a week or so, maybe 3 times a week in the PHP. So I'll pull up a diary card with a patient and say something like, wow, it looks like Sunday was really hard. You were feeling a lot of shame and sadness and you endorsed, high crisis modes in your diary card. Let's talk about what that was like for you. And so the answer is yes, I absolutely use diary cards and other sort of individually oriented interventions from DBT and find them tremendously helpful with this population. Again, really a dearth of literature. For example, anything about diary cards in perinatal, I was unable to find for this presentation, but I would happily write something about their usefulness sort of anecdotally in this program because I find diary cards to be tremendously helpful. And ultimately, we may also be using them to be able to generate some research too ourselves, so we can talk about the usefulness of these interventions with our population.
Great. Question from Tori. Can you give some specific examples of situations in which new moms who have been struggling have gotten relief by applying these skills?
Oof, that's a great question. Specific example ways in which new moms have gotten relief by applying these skills. I mean, I think that the skills come to mind for me that I think cause the most immediate relief would be the distress tolerance skills. So as I said, these can be really hard things to practice when you're with an infant. And I don't think that Marsha Linehan necessarily had in mind when she was developing the skills or what you can do with one hand or while you're sort of on no sleep and you also need to tolerate intense distress. So actually the distress tolerance skills come to mind as ones that I think can be tremendously helpful for immediate relief, sort of along the lines of what you're talking about. We use a lot of skills that tap into sort of the biology of distress to downregulate distress. So for example, one that's really popular in our program is the tip the temperature skill, which uses cold water actually to sort of incite in your body a parasympathetic response where it sort of deactivates from a fight or flight sort of activated response and invokes different systems in your body like slowing your breathing, decreasing your heart rate, and then also non-essential systems sort of shut down, such as like digestion, and that can enable your body to actually have like pretty immediate relief from distress. And I think those can be really helpful in providing relief, distress tolerance skills. As you said, Paige, before, the radical acceptance skills, I think, also can sort of enable people to come to terms with the fact that, for example, something isn't as they thought it would go, or that something about their life is very difficult to accept, such as loss, as came up before. And those ones too can sort of provide relief in that they enable you to think about something a different way or interact with something you're going through in a different way. And that's what these skills are really just meant to do, is make you think about things differently or feel as though you have tools to interact more effectively with what's going on in your life, which is, of course, very essential in the perinatal period when there are so many stressors and transitions.
Great. Question from Julia. Can you comment on how to use these skills to help parents with perfectionism in the postpartum period?
That's a great question. Actually, we do have a day during our skills group where we talk about perfectionism, and actually the skills we use to target them. Well, I should say that there is a sort of derivative of DBT called radically open DBT, which I mentioned briefly before, that's meant to address things like OCPD or paranoid personality disorder, avoidant personality disorder, disorders of over control. And those have to do with like spontaneity and deeper connection in relationships. And those are the ways that that particular treatment targets perfectionism. The way that we talk about perfectionism at the Motherhood Center, which I really enjoy, is self-compassion skills. There's a woman named Kristen Neff, who's a psychologist who researches self-compassion, who has on her website like a series of resources for self-compassion skills in particular. A lot of them are actually mindfulness based. For example, there's something called a loving kindness meditation where you sort of practice compassion for other people and then try to draw it inward towards yourself. I think her website is something like selfcompassion.org or like self-compassion Kristen Neff, you could Google and find quite easily. And those are the skills that I actually think are most helpful for perfectionism. But that's something that we talk about a lot. You know, we have mothers who are, for example, more prone to reason mind and sort of wanting to tightly control and be orderly about motherhood. And you really need to sort of invoke that self-compassion to target that perfectionism tendency.
And another question for you, Dr. Rimsky. How much do you explicitly spell out what you're doing? For example, try using the FAST skill versus speaking about the general idea with a patient or client.
Yeah, so maybe I'm very unsophisticated. I would say that I personally am very explicit. I think that it's important to be really transparent as a clinician and sort of say to people like, there's something I can teach you. Do you want to learn it? It's called the FAST skill. I'd like to see you practice the FAST skill once today, or I'd like to see you pick something from the pleasant activities list that you're going to practice, you know, between now and our next session. And I will be really very directive about it. And as I said, there's a lot of sort of training and teaching and modeling that goes on in DBT. And so for that reason, I will be very explicit.
Great. There is a question here about more in-depth DBT training specifically for the perinatal period. I don't know, Dr. Rimsky, do you happen to know of any such trainings?
I think we should do more.
I think we should too. I think we're going to add this to the agenda. So stay tuned, Dr. Bartlett and others that are interested. This will be the first of many more trainings that the Motherhood Center offers to clinicians of all different disciplines in the field that are interested in learning more about how to treat perinatal mood and anxiety disorders. And I also want to say that we are in the process of becoming accredited, so that at some point in the not too distant future, we will be able to provide CEs as well. And then Dr. Rimsky, just as a cherry on the top of today's excellent presentation, since we have just a few minutes left, if you want to walk our audience through radical acceptance, there was a question or two in here about that skill, just to familiarize everybody with what it is and what it entails.
Yes. Well, radical acceptance really is what it sounds like, although it's much easier said than done. It really does involve just radically accepting reality as it is. Sort of the "it is what it is" phrase comes in handy for this one, just sort of like really understanding and wrapping one's mind around the fact that what is happening to you in this moment happened for a series of reasons, you know, whether it be things that you can approve of or not, they can be things that you can accept. The acceptance skills within radical acceptance include things like turning the mind, which I mentioned, which is when you accept over and over again. Some people like to imagine sort of a dip in the road. You can go one way, which is rejection, or one way, which is acceptance. And you keep trying to make the acceptance turn over and over again, just to sort of come to terms with reality as it is. We also practice some mindfulness acceptance skills, such as something called half smiling, which is like a little smile like this. It's actually based on research that suggests that sort of mind follows body. So if you do something with your facial muscles, you can almost sort of trick your mind into feeling a particular feeling. This is based on research wherein people put a pen in their mouth, which forced a smile, and those people reported more elevated mood than the people who did not have a pen in their mouth. We also talk about something called willing hands, which is like keeping one's body physically open to whatever is going on in the universe around you. And those can be some of the radical acceptance skills that can be helpful. I believe when it comes to things like loss, of course, those things are very hard to deal with and cope with. And that's when I think the holding environment piece of therapy can be especially important too, in addition to the skills. But that's what radical acceptance is. And there can be so many things about motherhood that just have to be sort of accepted or surrendered to, as you would say, Paige. And I think that that's one of the reasons why that skill comes up so often and is so important for our mothers.
Such an important one. And as you said earlier, Liza, not one that you just try once and it sticks.
Yes.
Something that we definitely have to create a new neural pathway for. Well, Dr. Rimsky, I just want to thank you so much for everything you shared this evening with our audience.
My pleasure.
About DBT, I really want to thank everybody for coming. This was recorded. And so we will be making it available to all of you that registered this evening, as well as Dr. Rimsky's PowerPoint presentation. We will be sending it around. So thanks again. And if anybody is interested in reaching out to the Motherhood Center, we've got our information right there. You can email us at the info@ email address, or you can call us at the 212 number. We have care coordinators at the ready to answer any questions you or potentially someone that you referred to us might have. So thanks again to everybody. Have a great night and stay tuned for our next provider seminar in our series over the summer and for the rest of the year.
Thank you.
Bye.